talk about how to order diagnostic imaging study for eye care professionals. First, you have to decide where to send the study to be performed. Here are a few of my suggestions. First, it has to be a ACR, means American College of Radiology accredited facility, because to get the accreditation, they have to meet certain standard about the equipment, training of their staff, and interpretation of radiologists. So that is a minimum requirement to perform adequate study. And also a high multi-slide CT, preferably 64 slides. I'll show you why. It's not necessarily have to be 64 slides. All I'm saying is a thin slice, we can do multi-slice isovoxel acquisition with multiplanar reformat. That means you slice the patient in axial plane, and it's thin enough that you can use computer to regenerate different planes from coronal or sagittal, any plane you want, without rescan the patient. That is a basic requirement nowadays for any kind of orbital high resolution images. And also a same principle apply for the MRI. High field MRI 1.5 Tesla or above are good quality. 3 Tesla MRI is very accurate and high resolution for orbital imaging. Not every radiology group have 3 Tesla MRI. The group that has 3 Tesla MRI usually are the larger group and have more subspecialty training radiologists for the neuroradiology component of the practice. So larger practice, better machine with specialized interpretation usually will result in a more appropriate and better interpretation of the image. And then you have to decide whether you want a CAT scan versus MRI study for your clinical questions. So basically, for trauma, fracture, or foreign body, that's a CT study of the orbit without contrast. That's good enough. For inflammation, infection, or mass, we need contrast to define the disease extent better. So basically, if the patient is in the emergency room setting, that's pretty much a CT study. If patient can be imaged in outpatient setting, MRI is preferred, such as Graves' disease, exophthalmos, proptosis, pseudotumor, or vascular lesions. You have to decide contrast versus non-contrast for your study. For example, this patient has a right eye optic nerve swelling. Was sent over to rule out mass. This is a right eye. This is the imaging plane, axial plane. The nose is in front, the back, the tip of the head is into the screen, and the foot is towards us. So throughout mass, what is the relationship with the optic nerve of this lesion? Obviously, we can see a lesion in the orbital apex. Is this lesion pressing the nerve onto one side, or is this a lesion that's coming right from the muscle? Is it pressing against the muscle? You want to know where the lesion, what's the relationship to other anatomies. Here you just pretty much see a gray glob of tissue that is hard to define it. So here is a contrast study. This is a contrast study, which you see the lesion that enhance is a optic orbital apex meningioma. This lesion, the definition of the tumor is here, and then the optic nerve traverse through the center of the tumor and surrounding by this tumor, actually choked by this tumor because of the optic nerve sheaths. The CSF have difficulty draining from there. So contrast tell us a lot about where the lesion, where the anatomy, relationship to other vessels. For example, here are the intracranial vessels that you see better. This is non-contrast, contrast, non-contrast, contrast. To me, the analogy is like turning on the light bulb. You can find things easier with the light turns on. And also with contrast, you can predict where your medication goes, or where your chemotherapy goes, or antibiotics go, because wherever the blood goes is where your medication goes, and where the blood goes is also where the contrast, intravenous contrast goes. So that is very helpful information. Contrast also delineate vessel wall, artery, veins, different part of the body share the same kind of principles. This is the same patient that's in MRI. You see the meningioma that choking the optic nerve, and then the optic nerve sheath is dilated versus the normal left side. This is a illustration of the same process. Optic nerve sheath choked by this meningioma that have trouble draining the CSF back into the cistern in the brain. So this is an MRI study. This is an MRI study. Pretty much contrast enhanced MRI study show the same information as the contrast enhanced CT study, except you see more of the optic nerve and a nerve sheath. You can separate them apart. That's called soft tissue differentiation. And you have, even with contrast, you have trouble telling them apart in the CT study. So MRI study is better for evaluating soft tissues. But its bone is better with CT. You see the septation within the ethmoid air cells, and you have it's hard for you to see anything here. It's pretty much all black. So they complement each other. This patient is patient has a pituitary tumor. This is nose, this is eye facing this way. This is back of the head. Was referred from outside facility, which is also a high field MRI. It's a 1.5 Tesla MRI, but it didn't really have the resolution to answer the surgeon's question of where is the sellar diaphragm. Basically, you want to know where the lesion is above the sellar tursicus diaphragm, or is it below the diaphragm, because that will decide where he want to operate, either going from above or from the nose. If the lesion is below the diaphragm, he will go through the nose and resect it from the transnasal sphenoid surgery. Or if it's above the diaphragm, he will go from above. So the little diaphragm is quite important, but it's just kind of a stretch and push away by this lesion. Only with high resolution MRI, by the 3 Tesla MRI, you can see this little nibbit, little small tissue of diaphragm is still here. It's hard for you to tell from 1.5 Tesla low resolution. Now you have a better resolution telling the anatomical location of those lesions, and the surgeon will decide how to operate. Therefore, will avoid surgical complication during the surgery. So no surprise, during the surgery will result in better patient surgical outcome. This is a slide to compare the open MRI versus high field MRI. The open MRI is open on the side, it's not open front to back. A patient have less claustrophobic sensation, basically have less sensation of being closed into a small space. Patient like it, but the problem is the signal is from the patient is not as strong as the high field MRI. So the result is an image of the brain that is, you can see the rough anatomy, but you have trouble telling the gray matter and white matter, the difference and the resolution that you can see from high field MRI. The difference, the little white matter lines that you will just no way to seeing it in the low field MRI here. Open MRI here is a high field MRI. So just like analogy is a regular definition TV versus high definition TV. you can see the grass line clearly on high resolution, and you cannot see it on the low regular definition TV. Sometimes make a big difference when you want to you study the structure in detail. And especially for orbital imaging, all the structure are pretty small, so the demand for high resolution imaging is pretty high. And also, the 3 Tesla MRI cost about 5 to 10 times more to buy as compared to an open MRI, but patient and insurance pay the same for the same MRI anyway, so there's no reason not to ask for the better quality machine. For the CT slides, the same thing. It's same patient, four slide CT, 4-slide CT study versus 64-slide CT. It's difficult to evaluate the posterior fossa and the brainstem in this region because of the beam hardening artifact from the thick slice from the 4-slide CT. And now with a 64-slide CT, you can see anatomy much better. If to see it better, that means we can evaluate whether there is pathology or not. If you don't even see it, it doesn't matter whether there is pathology or not. You just cannot see it. So that's why we also want a good quality CT study to evaluate orbital imaging. Also, if you can describe the area of concern, ask the imager to label it on the skin, if possible, that will be very helpful. For example, this is an X-ray of a forearm that the patient had pain. And the first glance, I don't see any fracture from this patient. I don't see any bone malalignment. But this patient history was hit by a baseball. This 14-year-old fracture is better seen right here. It's a faint line because a technologist put a label right over the area of pain where patient placed, indicating to us. If patient doesn't know, say there's a palpable abnormality that the patient cannot palpate, and you can tell, describe to us, and tell the technologist to put a marker over the area of concern. And then when we're interpreting the image, then we know where to focus in. So that is very helpful. So just like this case with arrow, I can see a faint line here, and which is a faint line here. That's a fracture line. So you also want a neuroradiologist read your cases because it takes a lot of time to train a neuroradiologist. We have 4 years of undergraduate education. After graduate from college, and then we go to 4 year of medical school, and we go to 1 year of internship either in surgery or internal medicine, and then we go to regular 4 year of diagnostic radiology, studying all aspects of radiology. And in addition, we have to need 1 to 2 year of more subspecialized training, which is our neuroradiology fellowship is about. And then we have to be tested and certified by the American Board of Radiology. So we have to jump a lot of hoops to get to where we are, and then we like to use our expertise to help our patients. Larger group can subspecialize. Different doctors can subspecialize in different areas, and we consult each other. That is the way to provide better care compared to a jack of all trades. It's harder to maintain all your skill in different areas well across the board. So in summary, where to send the study? Send to an ACR accredited facility. CT slice, you want a 64-slide CT. Just some name that you can throw out that kind of a judge how new the facility's equipment, how up to date their equipment is. What I'm talking right now is year 2012. 3 Tesla MRI, and neuroradiologist to protocol means to decide how to scan the patient and to interpret the images. You can also get more information out of your imaging study if you provide plenty of history. Best to sign a copy of your most recent progress note because that way we know what you're thinking and you don't have to write much about it. Also, you want to describe the area of concern in detail. Say the lateral part of the orbit on the left side, and then we'll be more interested in that area, and then we'll try to answer your question in the report. And also, contrast injection give us the choice, because in outpatient imaging in United States, that radiologists cannot change the study without consulting with the referring physician. Inpatient, we have more choice. We can change the study, but outpatient, as long as you as the referring physician could be right, even though it may not be right, we usually cannot change your study. So I prefer you to give me the choice of contrast injection at our discretion with your history provided. And also request neuroradiologist to interpret the examination if possible, and also indicate the urgency of the study. If you want an emergent call after the study was obtained, you want to let us know, because anybody who get to it will get to it. May not be the neuroradiologist, but if its urgency is not high, then you can wait for a few days, because sometime our specialty radiology rotate through different areas of the practice, hospital, outpatient imaging center, different shift of the work. Then may not get to this case right away, but within a few days, usually we can get to it. So just indicate how urgent they are.